Great. Thank you, Dr. Abdullah. This was a wonderful session, and really appreciate your time and also how you've blended the spiritual as well as the scientific and then physical health aspects. My question for you is around preventative stenting. And if it's maybe helpful if I just give some quick context for yourself and for others on the call. You know, myself in my late 30s, I had undergone blood tests for my lipids because of a family history of cardiac disease. And everything is fine except for very elevated LP little a, lipoprotein small a, which was 5 times the max threshold. And so then I went on to have a CT angiogram, which led to a discovery of 50% blockage in the right coronary artery. Since then, I started on statins, esotrol, and I lead a relatively good sort of lifestyle in terms of diet and physical exercise. But nevertheless, the lipoprotein small a remains elevated. And now at 40 years old, retested another CT angiogram, intervention and lifestyle intervention. And so, at some point, I guess it's come up with my family doctor to consider a preventative stent, and would appreciate your perspective on that. Thank you.
That's an excellent question. It brings together a number of issues. And one of the most important issues you brought up is why South Asians get this disease at young age. I told you there are some genetic factors, and I told you there are 4 major genetic categories of problems that South Asians are born with that can cause higher risk of coronary disease and heart attacks. One of them is this little lipoprotein molecule. It's fat and protein mixed together, and it's called lipoprotein little a, LP little a, as opposed to lipoprotein big A, which is good cholesterol. So we're talking about lipoprotein little a, and that is the most injurious lipoprotein to the lining of the arteries of the heart. And South Asians and Black people genetically have that happen to them more than whites. So this is one of the reasons for increased risk of cardiovascular disease in South Asians. And it is completely and totally genetically determined. It is not lifestyle related. So whether you live a perfect lifestyle or you eat samosas for breakfast, lunch, and dinner, it's not going to change the LP little a level. It is a genetically determined production of a bad lipoprotein particle from your liver. So over the years, we've used statins to control lipids, but we have learned that statins and many other medications that we have used for cholesterol lowering have almost no effect on lowering LP little a, including niacin, very minimal effect in lowering LP little a. And then we have learned of these new medications that we are using that lower LP little a, as well as lowering your bad cholesterol and other things. And these are what is called the PCSK9 inhibitors. And they come as monoclonal antibodies. They come in the form of an injection. Monique, if I can get her to bring one, because I take it, so I can show it to you. Anyway, so this PCSK9 injection, you just need to take once a week or once every 2 weeks or once every 4 weeks, and it lowers your cholesterol level and protects you. So it's more than statins, and sometimes you have to take it with statins. So you are on Praluent, which is alirocumab, a monoclonal antibody, and you need to probably take it once every 2 weeks. There's a preparation of alirocumab that you can take once every 4 months, once every 4 weeks, sorry. So this is the little injection. Can you all see it? And all you have to do is take this cap off. You put it onto anywhere in your body or your thigh. I put it on my thigh. It's like a ballpoint pen. I press this little thing on top. I don't even feel the needle. It goes in and the medicine goes into my body. And because I don't even feel the needle, this thing that is clear medicine becomes yellow, and the thing clicks again like a ballpoint, and I know the medicine is in. So it's the easiest form of therapy and highly effective in lowering your cholesterol, but it also lowers your LP little a. And now we have another newer medicine, which is called inclisiran. And that's a messenger RNA messer upper of PCSK9. And that you only need to take once every 6 months. And it lowers all your cholesterol and your LP little a. So there is newer therapies underway. So we get to this point of preventative stenting. It is the worst possible thing that has been developed in cardiology. And I get passionate when I talk about this, when I see cardiologists stenting arteries and knowing full well that it is not going to benefit the patient. If you have one of those blockages I showed you earlier that causes angina 75, 80%, and it causing symptoms, then you can have medications you can take that control the symptoms and you can have good quality of life. If despite medical therapy, your symptoms persist and it's impacting your quality of life, then you should have an angioplasty or stenting. So it is good for uncontrollable symptoms that impact your quality of life. The second place where angioplasty and stenting is useful is where it saves lives. The patient is actually having a heart attack at that time. So here's the angiogram of another one of my patients. The right coronary artery is totally blocked at the top. It only had a 30% blockage before, and then went on to abrupt occlusion. And the patient was in the process of having a massive inferior wall myocardial infarction. I was able to get the wire across the artery, settle the balloon in that particular spot, blow up the balloon, and start getting some flow back into the artery, and then position my stents and stented the artery open so that it stays open, and literally reconstituted and recreated his large, complete right coronary artery. This saves life. So there are only two places where angioplasty and stenting is appropriate. One, where the symptoms are uncontrollable and your quality of life is impacted, you should have an angioplasty or a stent. Or when you want to save a life and you have the ability to get into a patient's arteries within half an hour, an hour or two of him having the heart attack, so you can limit the damage. Now, people say, well, my artery is now, it was 75, 80% blocked, it's now open, and so why does it not prevent me from having a heart attack? It does not, because the heart attack is not going to occur from that blockage or from that area of the stent. Heart attacks are going to occur from all those minor little 30, 40, 60% blockages that are not causing any symptoms, that do not need an angioplasty or a stent. And they are going to rupture suddenly because it's a vulnerable lesion in a South Asian, and it's going to clot, and the artery is going to be abruptly blocked. So angioplasty and stenting does not decrease the risk of you having a subsequent heart attack, and it does not prolong your life. It only prolongs your life in this setting where you are actually having a heart attack and you are able to go in and open the artery and reestablish the blood flow and stop the damage. A major study was published this year in January in the journal Circulation, and it clearly demonstrated that there is absolutely no role for preventive angioplasty or preventive stenting in coronary artery disease. And the only two times that angioplasty or stenting should be considered are those two. And if you're interested, I'll be able to send you a reference of that article, and then you can read it yourself. So did I cover the LP little a? Did I cover the alirocumab Praluent medication? And did I cover the indication or the use of angioplasty